At London Health Sciences Centre, we pride ourselves for the scope and quality of the care that our physicians, nurses, and staff provide. Our hospital provides the broadest range of specialized services in Ontario. This scope of services allows our highly skilled and world-renowned physicians and researchers to make an impact in every aspect of healthcare. The 5 physicians that you'll hear from today are specialists in different disciplines, and yet they treat a variety of conditions and diseases using similar surgical skills. Those skills include performing robotic-assisted surgeries, which are relatively new treatment options in the field of surgery.
We have learned over the decades, over the last century, that the very best surgeons and the very best surgical outcomes occur in the hands of those who show the greatest respect for their patients, not just personally, of course, but also in their tissue handling, causing the least amount of trauma, the least amount of bleeding, and the greatest care when they're performing surgery. And we teach our residents that in the operating room every day. But we now live in possibly one of the most amazing times in the history of surgery, because the rapid evolution of computer technology has now allowed us to bring computers and robotics into the operating room, where they can extend the range of human capability and give surgeons the ability to perform surgical procedures in a minimally invasive, computer-assisted fashion. That is something that was considered science fiction maybe just 20 years ago. So what you're going to hear from the rest of the speakers today is the amazing breadth of clinical activity that we offer here with the robot in London.
100 years ago, with prostate cancer, we rarely were able to cure this disease. Even 25 years ago, prostate cancer was caught typically at an advanced phase. There have been several revolutions for the care of men with prostate cancer, but one I would argue that is the greatest thus far has been the introduction of robotic surgery. I had the privilege to be part of the team that did the first one in Canada. We did that at University Hospital in 2004. And subsequently have gone on, and I've personally done the most robotic prostate cancer surgeries in Canada, 360 to date. I am tracking my outcomes very diligently, and we are seeing some definite benefits, as Chris alluded to, with blood loss. We're seeing improvements in urinary control. I'm seeing improvements in erectile dysfunction rates. So we are seeing the end product for these patients of improvement. I think the most dramatic impact that we're having is with respect to cancer control. In Ontario, Cancer Care Ontario did a review of all prostate cancer surgeries in 2006. And it was found that in 32% of the cases, patients had what's called a positive surgical margin. So a potential for leaving cancer behind and having to go on and have further treatments such as radiation. The Da Vinci robot in my series, the same equivalent patients, my positive margin rate is 9.8%. So I've taken it from 32% province-wide down to 9.8%, and that number is continuing to drop. So I think there is an impact with cancer care as well. Where are we going? Well, those other cancers I mentioned, kidney cancer and bladder cancer, are very common, and not just male problems. For kidney cancer, it's the 8th most common for women, and bladder cancer is 6th. The latest Da Vinci robot, which you see before you, will really facilitate our ability to do cancer surgery in those scenarios. Thus far, the earlier version of the robot that I have the privilege to use currently, it's not really technically feasible. There are some improvements with this instrument that will allow us to take this surgery and go further.
The problem with many cancers is that, notwithstanding all the advice about reducing risk and watching lifestyle and seeing physicians, the truth of the matter is that cancer can happen to any one of us, and it does. And what's important as it relates to the robot is minimal pain and suffering for patients. And to be able to provide a person in that kind of duress with a sense that they're going to be back looking after their kids or driving their kids to school, for example, or doing what they enjoy doing, which typically for so many people this time of year is gardening or being out in their back porch, and that they can be back to doing that in a week or maybe 2, rather than 2 months later still hobbling around and facing the ongoing sort of tiredness and weakness and all related to the surgical incision. That's extremely meaningful to those patients.
Head and neck cancer treatment's undergone some real changes. So up until about 2 decades ago, if you came in with a cancer of the tonsil or the back of the tongue, this is kind of what you got. This was standard of care. We would divide your mandible, do these radical neck dissections and take all sorts of tissue out, do these pharyngotomies, or go in through your neck. So these huge incisions, and the critical part about all of this is that we need to go through all these muscles on the outside of the neck that help to bring up your voice box. When you watch anyone swallow, you can see their voice box go up and down. And so unquestionably, this profoundly affected patients' speech and swallowing, and also their facial appearance. I mean, you think of some of the most things that you take most personally, your quality of life, your ability to eat, swallow, the way your face looks is why this is a particularly devastating disease. Transoral robotic surgery has really emerged in the United States over the last 5 years or so as a minimally invasive way to treat these cancers. And so we see these patients when they've healed up, and they're essentially like normal people. They speak well, they swallow well, and in our first series of patients, we've carefully selected patients that did not have any spread to the lymph nodes in the neck, and they've completely avoided radiation, and they're all doing extremely well. And so for select patients, this really seems like the right thing to do.
So cardiovascular disorder remains the #1 disorder worldwide, the #1 cause of death still. It's with making the operation less invasively where we can make people become more acceptable of surgery. The management of heart disease has evolved dramatically over the past 2 decades. The surgical treatment option must be tailored to each patient in order to optimize the benefits. Again, I emphasize that, optimize the benefits and minimize the risk of detrimental effects. Robotic surgery has allowed us to do that. So to define basically minimally invasive surgery or minimal access heart surgery, you make the incision size smaller. Cardiac surgery traditionally is performed by making an incision in the middle of the chest, cutting the breastbone in half, which is extremely invasive because the bone has to heal. So therefore, to make the operation less invasive, you make the size of the incision smaller, and you avoid cutting the breastbone, and you also avoid using the heart-lung machine. Heart surgery has, since its development, has been done utilizing the heart-lung machine. But by us also eliminating the heart-lung machine and using devices such as the robot that gives us the extra dexterity, gives us the high-definition visualization, we're able to perform operation on the beating heart. Over the last quarter of 20th century, surgery has been significantly shifted in terms of the way surgery is being performed. The invasiveness, as you've seen by all my colleagues talking about decreasing the invasiveness of surgery, we've been able to make surgery more acceptable with better results, fewer complications, and I think the most important thing is quicker return to functional health and productive lives. So we did a trial to see is robotic surgery better than open surgery. So we took 50 patients that all had single block arteries, and we said, okay, we'll do a bypass surgery on them without using the heart-lung machine, but by making a midline incision, cutting their breastbone in half, versus again, taking 50 patients in each of the different 3 robotic groups and following them after their operation. This was the most impressive thing. The length of time is spent in hospital. If you look again in blue, is the group that had conventional operation without utilizing the heart-lung machine, and these are the 3 robotic groups. Length of stay in the hospital was exactly by half. So this tells you how, again, as Dr. Schlachter showed, how we can use such a highly dexterous instrumentation to be able to bring sutures together. So in this situation, we resected part of the valve. Again, this is complete open heart surgery, and we're bringing the 2 other segments together. Again, this is looking inside the heart. This type of vision, this type of visualization is never, ever possible with conventional open technique. So this is an example of patients who undergo robotic surgery. Just as you see, 4 cold incisions. In women is extremely cosmetically appealing. They never see their scars. And this is a comparison where somebody has gone a midline incision where the breastbone has been cut compared to an individual who has gone, again, robotic, totally closed chest surgery. So in conclusion, thus far in our experience, robotic-assisted heart surgery is safe, effective, faster recovery, preserved chest cavity stability, smaller incision results in reduced wound pain, reduced blood loss, less transfusions, earlier discharge from the hospital, and earlier return to routine activities.
I had an appointment at a leading hospital in Toronto to have my valve repaired. And I was booked within 2 weeks to have open heart surgery, which is normal with a valve repair. But what scared me was the fact that I was going to have my chest broken, and I didn't like that, especially after reading the booklet about recovery process. And the things that I liked doing, I couldn't do for at least 6 months. So I Googled, and I found Dr. Kia. My surgery was successful. And Dr. Kia said to me, when you go home, you can do whatever you want to do. If it hurts, don't do it. Within a week, I was cooking. I was sweeping. After 2 weeks, the grass was growing, and no one to do it. So I got the weed whacker out, and I weed whacked. So after, that was 2 weeks, 3 weeks, I cut the front grass with a push mower. After 4 weeks, my husband gave up, and he allowed me to do my thing. And all I can say, if I had an open chest cavity heart surgery, I wouldn't have been able to do the things that I can do today.
We've run a little bit over time. There's a good reason for that. When you get a group of surgeons like this, myself included, who are so passionate about what we do and the opportunity to deal with this new technology, it's hard to shut us up, right? So we're going to go on about what really motivates us and what excites us. We have a robot. We've made immense use of it already at University Hospital. We have provided this host of world and Canadian firsts, and we have led the way as far as the rest of the country is concerned. Adopting this new technology now and getting this both for UH and Victoria Hospital is going to allow us to continue to push that frontier. So in this world, you can either be leaders or followers. London have been very much punching above our weight in terms of leading the way with computer-assisted minimally invasive surgery and this technology, both in terms of caring for our patients here in London, but also advancing quality of care across the country.